Hello and welcome back. Uh, Today we'll be discussing the histological considerations in the diagnosis of glomerulonephritis, and this will be second talk under this heading. And this is part 4.4 of an approach to peripheral edema. So, as we discussed in the previous video, this is what we have used as a schematic to understand the various pathomechanisms of glomerulonephritis. This was extrapolated by me previously to this slightly more anatomically, accurate schematic. So this is more anatomically accurate, and then we understood that in reality this is what the glomerulus looks like. Okay, so this is the vascular pole, and this would be our proximal convoluted tubule, and we've discussed the rest of the structure. Now, in the previous discussion, we discussed the morphological spectrum that correlates with the presentation of nephritic syndrome clinically. Of That included non-cricentric immune complexes mediated glomerulonephritis, and it included cricentric glomerulonephritis with or without immune complex deposition. Then we discussed the histological correlates of three specific etiologies that result in nephritic syndrome. That was Goodpasture syndrome, IgA nephritis, and finally infection-associated glomerulonephritis. So today we're going to discuss the histological correlates of specific etiologies that result in nephritic syndrome, which at times in some patients can have nephrotic range proteinuria. So this will include the histology of membrano-proliferative glomerulonephritis, C3 glomerulonephritis, and we'll discuss in detail what plasma cell dyscrasia related glomerulonephritis looks like. And I'll also, fill in the blanks for of the entire spectrum of monoclonal gammopathy of renal significance. The histological correlates of the final talk part of the talk will be understanding the histological correlates of microangiopathic hemolytic anemia. That would be your thrombotic microangiopathy. So let's start off with membrano-proliferative glomerulonephritis. See, before I go into this, or you listen to me go talk about it, I would strongly suggest you watch the video on peripheral edema part of approach to peripheral edema part 4.1. That was the talk on nephritic syndrome, the second talk, because I've talked about the mechanism in great detail there, and they are very relevant to understanding of the histomorphology of these of the glomeruli in these disorders. Okay. So now, in membranoproliferative glomerulonephritis, as compared to a normal glomerulus, as you can see, there are a few very characteristic findings. The first finding is what I've shown in this schematic as a obliteration of the lumen of the capillary by endothelial proliferation. Okay. The second finding is again an obliteration of the lumen of the capillary by in this particular case neutrophils as well as endothelial proliferation. Okay, and finally, there is some mesangial proliferation. As you can see, this would be the vascular pole, so it is away from the vascular pole. So there are more than three mesangial cell nuclei located together at a position away from the vascular pole. So this would be mesangial proliferation. Now, in addition to that, there is a thickening of the basement membrane here. Now, I have purposefully not made it very conspicuous because even in light microscopy, you usually don't find a very conspicuous basement membrane thickening. So, this is something that is seen only occasionally, and we call that wire loop lesions, in at least in lupus nephritis, but also in generally in membranoproliferative glomerulonephritis. So they're not very conspicuous on light microscopy. You can only find them if you look for them. So we'll that is why I've made it not as obvious as the rest of it. Now, this basement membrane thickening is why we call it membranoproliferative. So the proliferative part is from what we discussed previously, that is immune complex mediated proliferative glomerulonephritis that we discussed in a previous talk. But the membrano part implies that there is thickening of the basement membrane. Okay, so this is what the normal glomerulus looks like under the microscope. Again, this is the vascular pole, this is the proximal convoluted tubule, and these are the tufts. Okay, and they're not clearly, you cannot clearly decide where the one tuft starts and the other stops. And you can see within each tuft there are clear open capillary beds, and there are RBCs within those capillary beds. Now, in addition to this, we'll see what happens in membranoproliferative gene. So this is a case of membranoproliferative gene. Okay, so right off the bat, it is very clear that the glomerulus appears to be enlarged in size. That is because the number of cells within the glomerulus have increased. Okay. Now, if you look carefully, actually there are some very specific findings that you can see. The first is, in this particular part of the tuft of the glomerulus, there is a lack of RBCs and open spaces. That is because the capillaries are completely obliterated. Now, that is because of endocapillary proliferation. Now, this endocapillary proliferation is, I can say it is due to neutrophils because there is a neutrophil here. Okay, there is a neutrophil with a classic neutrophil morphology. That is, there are three lobes to the nucleus. So I can say that there is some neutrophilic infiltration there. Okay. Now, again, in this particular part of the glomerulus, again there is a neutrophil, but there are also a lot of other bizarrely shaped nuclei. That is due to endothelial cell proliferation. So, see here you find both neutrophilic and endothelial cell proliferation, and here also you find the both of them. But just to highlight the point, I've labeled them separately. Now, the next thing that you find is this is a capillary here. Right next to the capillary, there is a space that is actually the mesangium, and in the mesangium you find multiple nuclei, definitely more than three nuclei, and therefore there is mesangial proliferation. Okay, there is a slightly open glomerulus capillary bed here also. Now, finally, we see thickening of the capillary bed. So actually, this is the thickened capillary bed, and it is a little difficult to see. It's only when you see an open capillary that you see that the wall of the capillary is actually thickened. Okay, so these are the four things that classify a patient as having membranoproliferative GN. Now, if I was to do silver staining for the basement membrane, what I would find is that there are deposits within the basement membrane, and there is duplication of the basement membrane. So what ends up happening is the basement membrane grows around the deposit. So this being the deposit, and the basement membrane then grows around it like this. Okay, so this, when I use a silver stain to highlight the green portions here, what I get is two parallel lines with the amorphous material in between. And that is what we call tram tracking. Okay, that is the morphological appearance of tram tracking. Uh, Again, that should suffice to say that this is a case of membranoproliferative GN. Now, when you get a glomerulonephritis, that is clinically a nephrotic syndrome, sometimes with nephrotic range proteinuria, sometimes not. Okay, there are two distinct possibilities that one must consider. One is C3 glomerulonephritis, and the other is plasma cell dyscrasia related glomerulonephritis. What has been called monoclonal gammopathy of renal significance, or at least it is a subset of MGRS, of monoclonal gammopathy of renal significance. So let's talk about C3GN first. Now in C3GN, as we've discussed, there is C3, alternate complement activation related pathophysiologies fall along a genetic spectrum. Yeah. And similarly, they also fall along a morphological spectrum. So there is a histomorphological spectrum with dominant C3GN, because on one side you have just C3 deposition without any proliferative changes. Then you have C3GN with dense deposit but no proliferative changes. And then we have membranoproliferative, that is proper proliferative changes with with the basement membrane thickening, again with dominant C3 deposition. Okay, and we discussed previously that it is these proliferative glomeruli, patients with these proliferative glomeruli that stain dominantly for C3, that show the highest prevalence of C3 nephritic factor in the serum and the lowest C3 and C4 levels. So I hope that much is clear. Now, these are three glomeruli that I've shown. The first glomerulus is a normal glomerulus. Okay, so that's a normal glomerulus. This would be a C3 glomerulonephritis without any membranoproliferative pattern of glomerulonephropathy. These two glomeruli here, these are clearly not normal. There is a very prominent lobularity. There is they seem very busy. There are a lot of cells that have infiltrated into the glomeruli. Okay, now, so these are different. These are membranoproliferative GN, and since I'm talking about cases where C3 has been immunohistochemically, on immunofluorescence found to be strongly positive, these are C3 glomerulonephritis with membranoproliferative changes. That could be with or without neutrophilic infiltration. So on this side, we don't have significant neutrophilic infiltration. On the right side here, we have very prominent neutrophilic infiltration. So on this glomerulus, we have very prominent neutrophilic infiltration. Now, again, the exact histological morphology is something that one needs to actually see the slides to be able to diagnose using that. But see, from a clinical standpoint, that is from the point of view of somebody reading a glomerular biopsy report, These are the things that we're looking for. We're looking for whether or not there were proliferative changes, and if there were proliferative changes, were there, visible neutrophils within the glomerulus or not. So these will be mentioned by the pathologist. Okay, and then when they write correlate clinically, this is how you correlate clinically. So as you can see, that C3 glomerulonephritis falls along a spectrum of morphological changes. All of these three glomeruli would stain on immunofluorescence strongly for C3. So this is C3. Why is it C3? Because I have stained for C3. Okay. Now you can see that the deposition is clearly around the basement membranes of the glomerular capillaries themselves, and therefore they have this kind of pseudo linear pattern. Okay. So these are all three, although morphologically very different, C3 glomerulonephropathies. Now coming to monoclonal gammopathy of renal significance. Now, see, the thing is that this MGRS actually has a lot of entities under it. So we've discussed four and their clinical correlates, and we'll try to understand them a little bit more. Once the histopath report comes back, the diagnosis often changes subtly. So we need to we need to understand what exactly that means. Okay, what does it mean when the report comes as what I'm going to tell you. So on one side, you've got some monoclonal immunoglobulin component deposition. This you would demonstrate by doing IgG or light chain kappa or lambda immunofluorescence microscopy. Whereas if these two are negative, then we would say that there is no monoclonal immunoglobulin deposition. And in that situation, this would be a patient who has got a monoclonal gammopathy, that is, they have a serum M band. Okay, when you do serum protein electrophoresis, and the biopsy then shows C3GN, that is not light chain deposition, but rather C3 is getting deposited. Okay, or they have thrombotic microangiopathy. And as we discussed previously, this would be due to the presence of a C3 nephritic factor in serum. That is something that, either activates C3 or inhibits factor IA or factor H. Okay. Less commonly activates factor 4, factor 5, as we've discussed previously. Now, these are the entities that show positive immunoglobulin deposition and or positivity for kappa and lambda light chains. Okay, so based on their physical structure under the microscope, they are divided into two. They are divided into organized deposits and non-organized deposits. Okay, we'll start with non-organized because they are fewer in number. So when you have non-organized deposits, there is IgG or kappa lambda light chain staining, and the deposits are not organized. We divide them based on the presence or absence of proliferative changes. That is, whether or not there is membrano-proliferative glomerulonephritis on light microscopy. So when you have proliferative changes, we call that proliferative glomerulonephritis with a monoclonal immunoglobulin deposition. Because now, please remember, in the previous step, we have already demonstrated that monoclonal immunoglobulin is deposited there. Okay. Now, if it is not, there are no proliferative changes, then we call that monoclonal immunoglobulin deposition disease. That's it. Okay, so these acronyms are standardized, so one must know them. So that is proliferative GN with monoclonal immunoglobulin deposition and monoclonal immunoglobulin deposition disease. Okay, PGN, MID, and MID. Okay. Now, again, the deposition is different in these two cases. So, proliferative glomerulonephritis would naturally have complement activation. Okay. So, since it has complement activation, the most commonly what is deposited is IgG3. Okay. And to a lesser extent, IgA, and then very rarely IgM, but not light chains. Okay. Because light chains in themselves cannot activate complement. On the other hand, when you have no proliferative changes, you could have complete immunoglobulin getting deposited, which is not very good at activating complement for some reason. Okay, probably it is not functioning. Okay, or you could have light chain deposition, you could have heavy chain deposition. Okay, the most common form is actually heavy chain deposition, and that is a truncated version of IgG1. Okay, now heavy chain diseases will be coming to in our discussion on plasma cell disorders specifically, but suffice to say that this would be a subset of patients with Franklin's disease, which is IgG heavy chain disease. Okay, and also a subset of patients who have CLL with a heavy chain restriction. Now, the site of deposition of this complete immunoglobulin is always glomerular. That is why the process is predominantly within the glomerulus. So in the glomerulus, as we would expect, because it is membrano-proliferative, it is subendothelial or mesangial more than subepithelial. Okay. Now, in case of monoclonal immunoglobulin deposition disease with light chain deposition and or heavy chain deposition or complete immunoglobulin deposition, you usually have glomerular deposition, but you also have tubular basement membrane deposition. So again, this is something that on light microscopy you correlate with immunofluorescence, and then you come to a diagnosis. Okay, so I hope we're clear. This is non-organized monoclonal gammopathy of renal significance, in which you have immunoglobulin deposits on the histomorphological, on the histopath specimens. Okay. Now coming to monoclonal gammopathy of renal significance with immunoglobulin deposits that are organized. Okay. Now these are four pictomicrographs of electron microscopy that I have shown. So as you can see in the first one, there are some randomly oriented fibrils. They are so small that it almost looks like, it just looks amorphous. Okay. And often the report will tell you that there are the diameter of the mean thickness of the fibrils is around 10 nanometers. Okay, at least the questions in MCQ exams will specify this. Okay, and as you can see, the magnification is 49,000 times. Okay, now in the second thing, we have a randomly oriented fibrils with a mean thickness of 50 nanometer. So this was 10 nanometer and this is 50 nanometer. Both are randomly oriented. Okay, so this is random. On the other hand, so when you have this, we call them fibrillary deposits. So fibrillary is random. Fibrillary essentially equals random deposition, but on electron microscopy. Okay, and that basically means they are solid and they do not branch. So they sit like this. Also, that each individual fibril is not hollow. It is a solid fibril. Okay. Now, so this is random. So these are divided into two types. The most common type is what we know very well, that is amyloid, in which case the mean diameter is usually 7 to 12 nanometer, that is slightly smaller. Okay, but we also discussed that we have got certain other fibrillary deposits which are called monoclonal fibrillary glomerulonephritis. Okay, so here the diameter is slightly larger than that for amyloid and lies between 10 and 30 nanometers. Okay. Now, on the right side of your screen, what I've shown you are microtubules. So, microtubules are basically hollow structures. Okay, hollow structures. They have a lumen. Now, these hollow structures are organized either in parallel arrays, as in they form these shapes, or they can be organized like in the second situation, that is they are deposited as in a random pattern. So you can see the hollow structures in between, they look very similar to the fibrillary deposits, but again the size is very different. Okay, now these two fall under what we call microtubules. So why is this microtubule? Because it's hollow and it may show branching. Okay, and the diameter on average is larger than that of fibrillary deposits. So there are two types of microtubular deposits. The first one that I showed are slightly smaller. They are called immunotactoid glomerulonephritis. And the larger ones, that is with a mean thickness of over 29 nanometers, are what we call cryoglobulinic deposits. Okay. Now, the thing is that immunotactoid glomerulonephropathy is a pure glomerular disorder. Okay, whereas we know very well cryoglobulinemia causes a vasculitis. So cryoglobulinemic vasculitis occurs and it also gets deposited along vascular vessels, and naturally it can affect extrarenal tissues, which we know very well from the fact that the classic triad of your cryoglobulinemic vasculitis includes both peripheral neuropathy, arthropathy, and glomerulonephritis. Okay, so this is our uh, these are the two types of the organized deposits that we've talked about till now. There is a third type, that is the crystal variant. So these are proper crystals which may be outside the cell or inside the cell. Now, importantly, these crystals are always kappa light chain, because if it was lambda light chain, it would form amyloid. Okay, and we've already discussed in our talk on the mechanisms of how kappa light chains cause damage, that these crystals that are formed by kappa light chain happen very specifically when there is a problem with the complementarity differential determining regions 3, and that produces a hydrophobic pocket that causes them to polymerize. Okay. So these are three electron microscopic images showing. On the first one, that is this image, it shows something very interesting. It shows a lot of polygonal shaped this thing include polygonal shaped crystals which are both rod-shaped and rhomboidal in shape, which are located within proximal convoluted tubules in this diagram. Now, how do I know this is a proximal convoluted tubule? It is because of where I have taken the pictomicrograph from. So again, like I said, clinically, what is important is to pick this up on the report. Okay, not the morphological findings per se. But again, if you're finding crystals in the morphology, they will send you a photo pictomicrograph and they will label the structure as a PCT cell. Okay. Now, this is what we call a light chain proximal tubulopathy or LCPT. Okay. Now, this is what was causing Fanconi syndrome. So, if you recall from my talk on the on plasma cell dyscrasia related glomerulonephritis, we had discussed that kappa light chains can both get deposited in the glomerulus and cause a nodular sclerosing variant of glomerulonephritis. They can get deposited and just cause mid, that is, they cause no morphological changes, but they cause nephritic range proteinuria and that kind of a presentation. And they can get deposited in the proximal tubule, can cause your Fanconi syndrome. Not to be confused with Fanconi's disease, okay, which is a congenital aplastic anemia. Okay. In the second case, we have numerous light chain crystals with a rod, triangle, or rhomboid shape. Now, importantly, these are located within the cytoplasm but often infiltrating histiocyte. Okay, and how do I know this? Because of the morphology of the nucleus. Okay, uh, okay. Either way, that's not the nucleus, but because of the morphology of the nucleus in the other parts of the that is not shown in this particular pictomicrograph. Now, the thing is that these are the crystals. Okay, they are very characteristic shape. These were rhomboid or polygonal. These are very characteristically, they have sharp edges and they look like basically they look like your pavement, crazy pavement pattern. Okay. Fine. So this happens in a specific subvariant of MGRS called crystal storing histiocytosis. Now, this is the second variant that can have an extrarenal manifestation. So we've discussed cryoglobulinemic glomerulonephritis can be associated with extrarenal involvement because of vascular involvement. Similarly, crystal storing histiocytosis can cause extrarenal manifestations. And obviously, naturally, as would be expected, it is in those tissues that have the highest histiocyte density. So that would include bone marrow and lymph node. That would naturally include the Langerhans cells within cutaneous and subcutaneous tissue. It will also include the parotid glands, the brain, the lungs, the liver, thyroid, and synovium. Okay, an important exclusion here is it is not usually found in the spleen. Again, that is primarily because the spleen is not usually taken for histopathological evaluation. Okay, but it is otherwise found there. Okay. Now, finally, we have these needle-shaped electron-dense crystals. I have shaded them in red. Now, they are located in the mesangium and within the phagolysosomes of infiltrating inflammatory cells. Okay, and these again form a very interesting subvariant, which is called the crystalloglobulinemia. Okay, now sometimes it deposits on exposure to cold. So in that situation, it is called cryocrystalloglobulinemia. Okay, and this is the third variant of MGRS that can have an extrarenal manifestation. So they actually can get crystallized within arterioles and glomerular capillaries, causing a secondary thrombosis. Okay, this looks very similar to cryoglobulinemia, cryofibrinogenemia, but is significantly less common. Okay. So these are the three crystalline variants. Now please understand that the classification here is purely based on morphology. I divided them into fibrillary, then and microtubular, and then crystalline. Okay, so again, that was based on morphology of the deposits on electron microscopy. Okay, so unless you've done electron microscopy, you will not be able to differentiate between them. Okay, now light chain proximal tubulopathy can also rarely occur due to a lambda chain. In such a situation, it usually does not cause Fanconi syndrome, and this is very important. It is very rarely then associated with Fanconi syndrome. And second, it can cause acute interstitial nephritis, which will be the next topic of discussion in this series. So, when you have interstitial nephritis, also a patient can have a MGRS, and in that situation, it is usually a light chain proximal tubulopathy with lambda chain deposition. Okay, fine. Now, in summary, MGRS associated diseases are divided into two. That is, we have monoclonal immunoglobulin deposits can be demonstrated, and monoclonal immunoglobulin deposits cannot be demonstrated. Okay. Now, when they cannot be deposited, it is either C3GN. Okay, so this is C3 that is deposited here, or it is thrombotic microangiopathy. Okay, when there are immunoglobulin that the immunoglobulins that have been deposited, then that is divided into either organized or non-organized. We start with non-organized because they are smaller, lesser in number. They are either monoclonal immunoglobulin deposition disease, in which case it can be a complete immunoglobulin, it could be say, light chains, it could be heavy chains. But the important thing is on light microscopy, you do not find any membrano-proliferative changes. The microscopy is relatively normal. Where the other end we have got PGN MID, that is your proliferative glomerulonephritis with monoclonal immunoglobulin deposition. So in that situation, we have whole immunoglobulin deposition, because if it was just light chain or heavy chains, it would not be able to activate complement and therefore would not be able to cause those proliferative changes. Now, when it is organized, we divide it into three. That is fibrillary deposits, microtubular deposits, and inclusions or crystalline deposits. Okay. Now, the fibrillary deposits, there are of two types. That is amyloid, which is the classical one that we are aware of, in which case it will always be lambda deposition invariably. Okay. Or it could be a monoclonal fibrillary glomerulonephritis, which is IgG1. Okay. And on the other hand, microtubular includes immunotactoid glomerulonephritis. Now, immunotactoid glomerulonephritis is a full-fledged immunoglobulin deposition, so it is IgG. Cryoglobulinic is invariably IgM deposition, as we will discuss when we discuss glomerulonephritis. Uh, and that is what we've shown with immunohistochemistry. Now, light chain proximal tubulopathy, crystal storing histiocytosis, and your cryocrystalloglobulinemia, all three are due to kappa chain deposition almost always. The only exception being LCPT sometimes is lambda, and in that situation it causes interstitial nephritis. Okay, so now the differentiation is based on their site of deposition and what cell is affected by the deposition. Okay. Now, again, just to reiterate, very importantly, the ones or the entities here that can present with some systemic manifestations include your obviously your cryoglobulinemic glomerulonephritis. They include crystal storing histiocytosis, in which case the predilection is for those organs that have a large resident population of histiocytes or dendritic cells. And it can include cryocrystalloglobulinemia or just crystalloglobulinemia, in which case the crystals deposit within the vessel and cause occlusion, mimicking your cryoglobulinic vasculitis. Okay, so that is your entire spectrum of MGRS. See, clinically, when I discuss it before the biopsy has come, I cannot go into so much detail. I hope me going about it in a step-by-step pattern has been helpful. Okay, now moving ahead, this was what we had described as the clinical spectrum of plasma cell dyscrasia related glomerulonephritis. So before your, before your electron microscopy reports have come, or if in case you've not sent them at all, you'll actually be dividing these patients into light chain deposition disease, okay, amyloid glomerulonephropathy, fibrillary glomerulonephropathy, and immunotactoid glomerulonephropathy. Now, if you remember, fibrillary, we had an additional marker on immunohistochemistry called DNA JB9, which is an MCQ question, and we had discussed the association. So, amyloid glomerulonephropathy obviously can be associated with most commonly abroad in the US and in other Western countries with chronic inflammation in RA and ankylosing spondylitis, and in India and other countries that have endemic tuberculosis, it's tuberculosis. Okay, similarly, fibrillary glomerulonephropathy occurs with both malignancies and autoimmune diseases, and this is an important thing to understand that fibrillary glomerulonephropathy can occur with autoimmune diseases also. So again, it would come to an internist or a specialist in clinical immunology and rheumatology. And whereas immunotactoid always presents with CLL, SLL, and B cell lymphomas. Now, we have discussed the clinical presentations of these three disorders. All of them were discussed under your nephritic syndrome with or without nephrotic range proteinuria. And I had discussed the prognosis based on what you found on microscopy. Okay. So, if it was light chain deposition disease, that had the worst prognosis, whereas amyloid, especially AL amyloidosis, because of the extensively, because of the great treatment options we have for multiple myeloma now, we had significant response rates. Okay, and very low progression. So this was a table from mechanisms of plasma cell dyscrasia related glomerulonephritis. And again, now just correlating the two, this the light chain deposition disease entity here would include, really it would include non-organized deposits in the form of MID, that is monoclonal immunoglobulin deposition disease, but not PG and MID. Okay, why? Because PGNMID is a full immunoglobulin deposition. May have full immunoglobulin deposition, but can also have kappa chain deposition. So therefore, or lambda chain deposition. Therefore, it would be light chain immunoglobulin deposition disease. Now, among the organized deposits, this includes only the crystalline deposits. That is your LCPT, that is light chain proximal tubulopathy, your crystal storing histiocytosis, and your cryocrystalloglobulinemia. Now, importantly, LCPT can be also lambda, but all the others are kappa chain deposition diseases. Okay. So I hope that much is clear. Now, moving ahead to the next entity, that is your thrombotic microangiopathy on histology. So, the histological correlates of nephrotic syndrome with a microangiopathic hemolytic anemia on clinical orientation, now clinical presentation. So, again, I would urge you to see the approach to peripheral edema, part 4.2, that is your microangiopathic hemolytic anemia. To gain a deeper understanding of what I'm about to discuss in histopath. Again, the two discussions in standalone are empty and they do not complete. They are not complete. But once taken together, you will get a detailed and rich understanding of the process. Okay, so we again, like I discussed with urticaria, these are three capillaries. There is an arterial end to the capillary, there is a venular end to the capillary. On the venular end, you see these high endothelial vessels. Okay, on the arterial end, you see your normal endothelial cells. So in the normal case, we have some proteins within the blood that are not getting filtered because the spaces in between the capillaries, capillary endothelial cells do not allow them to get filtered. So those same proteins go ahead, they get slightly concentrated, but not very significantly, and then they leave through the venular route. Now, what can happen is when you have some kind of endothelial cell contraction, the spaces in between the endothelial cells, that is, these spaces can become larger. Okay, so because of that enlargement of these spaces, you end up having a loss of the protein into the extracellular space. Okay, now, this kind of loss of protein into the extracellular space under the microscope would look like an amorphous eosinophilic deposit around the cell, around the blood vessel. Okay. Now, alternatively, what can happen also is that there is a lot of loss of water. That is, the water component of serum, and as a result, the protein gets highly concentrated. And because the protein is getting concentrated, and because for some reason the protein has a tendency to clump together, it is forming a clump and obstructing the capillary. Okay, so this here is what we call a fibrinous exudate. Okay, so this is the fibrinous exudate that gets deposited. Okay, and the second situation is what we find in cryoglobulinemia or cryocrystalloglobulinemia, where the crystal gets deposited within the vessel, as a result, occluding the vessel and resulting in distal infection. So what I am interested in thrombotic microangiopathy is actually the center pathology. That is, when there is, for any reason, endothelial activation, as we've discussed, this could be due to alternate complement activation. This could be due to, this could be due to a toxin like a sugar toxin. Okay, because whatever may be the reason, there is endothelial activation, and that endothelial activation results in leakage of protein into the surrounding extracellular matrix. That is what you see as a fibrinous exudate, and I'll elucidate this a little bit more in the next part of this discussion. Okay. This is the presence of a so basically what a fibrinous exudate on microscopy indicates is that there is increased capillary permeability to high molecular weight proteins like fibrinogen. Okay, now this need not always be due to inflammation, although it can be due to inflammation. Okay, so inflammation can also cause endothelial contraction, which is the first step of normal inflammatory processes in the blood vessel. Okay, and but what will happen is that the inflammatory cells that will come here, that is the neutrophils and your histiocytes, they would come and start degrading this fibrinogen. So you would not find the fibrinogen. So if you see this kind of amorphous deposit around blood vessels, that indicates that fibrinogen was deposited because there was increase in capillary permeability. But that fibrinogen has not been degraded. So therefore, the process that resulted in increased capillary permeability was not an inflammatory process. Okay, see the logic there. Okay. So this is what we call an acute thrombotic microangiopathy. Okay. So what you see is something very interesting. What I've highlighted there is the glomerulus with a fibrin thrombus involving the arteriole and extending into the glomerular tuft. So this is the arteriole. Sorry, I'll use a different this thing. So this is the arteriole, and then the fibrin thrombus is extending into the glomerular tuft distally. Okay. The second diagram I have highlighted with the yellow, the glomerulus with a prominent fibrin thrombus involving the hilar vessels and extending into the glomerular tuft. So this is the hilar, these are the hilar vessels, and again these are the yellow, what I've highlighted in yellow are the extensions into the glomerular tuft. Okay. And in the final diagram, we have a glomerulus with endothelial swelling, giving it a bloodless appearance. Okay, that's all. But as you can see, unlike what we saw with membrano-proliferative glomerulonephritis, even though there are very few RBCs within the glomerulus, there is no increase in the number of RBC, in the number of nuclei that you see in the glomeruli. So they don't look busy. Okay, they look essentially like normal glomeruli, but just that the capillaries have collapsed for some reason. Okay, and again, the entire glomerular tuft has not collapsed like we saw in collapsing glomerulonephropathy. What has actually happened is that the tufts are still maintained. It's just that the capillary lumens are obliterated. Okay. Now, see, when I say fibrinous exudate, what do I mean by exudate? Exudate implies that fluid has escaped from the vasculature due to increased capillary permeability. Okay, this in turn could be fibrinous. That is, you could have a non-inflammatory increase in capillary, permeability, as I just discussed. This would be due to either endothelial activation and or mechanical stretch. Say the pressure within the capillary suddenly increases so much that the endothelial cells are literally pulled apart. Okay. This would result in high molecular weight proteins like fibrinogen getting deposited in the extracellular matrix around the blood vessel or within the blood vessel. Okay, so that is what we see here, in here, and then again in this. Okay, here in a vessel outside. Now, this is non-inflammatory because there are no inflammatory cells and the deposited fibrin is not getting degraded. Okay, so this is clearly a non-inflammatory microangiopathy or thrombotic microangiopathy. Okay. Now, again, you could have exudate due to inflammation and you could have it also due to bleeding. Okay. But that is not what we are seeing here. What we are seeing here is non-inflammatory, non-hemorrhagic exudate. Okay. So if in pathology we have an exudative fluid accumulation and there are certain contains inflammatory cells, then we call that a purulent exudate. Although I don't really like that term because purulent is paying homage to what you would see clinically, but you would need not to actually see pus clinically in every situation. Okay, so I don't like the term much. And again, it contains RBCs on the histology, and they call it hemorrhagic, but hemorrhagic again would be a cross morphology. Okay, so either way, I'm not very big fan of these two terms, but that is what they're called. Okay, but we here what we have is we have exudative, we have a fibrinous exudate that is non-purulent and non-hemorrhagic. Okay, and that is what defines thrombotic microangiopathy. Now, again, these are the acute, this is what happens acutely during a particular case of thrombotic microangiopathy. But once the process becomes chronic, okay, once the process becomes chronic, what ends up happening is that there is proliferation of the cells that line the wall of a normal vessel. So what we end up getting is this concentric increase in cell number of cells, and they are spindle shaped cells. They're essentially just proliferating pericytes that have converted in fibroblasts, and this is what we call onion skinning. Okay, so this is a glomerulus. This is a glomerulus. Okay, with a prominent fibrin thrombus. Involving the hilar vessel. Okay, so this is the hilar vessel, and there is a fibrin thrombus there. And you also see that there is a vessel right next to it. That thrombus has been the thrombus within the vessel has been infiltrated by fibroblasts, and they are producing collagen. And then there are rings of fibroblasts around the blood vessels, essentially completely obliterating it, producing onion skin. Okay, so this is what we call a chronic thrombotic microangiopathy, and this is what we call an acute thrombotic microangiopathy. This is what I would expect in a patient who has a nephritic presentation with clinically also having microangiopathic hemolytic anemia. Okay. Now, before we end, we'll just summarize everything that we've discussed. Okay. First is that the morphological spectrum changes that correlates with what we've discussed is the morphological change, spectrum of changes that correlate with the clinical presentation of nephritic syndrome, and we discussed how non-cricentric immune complex mediated glomerulonephritis, what it looks like under the microscope, and we discussed cricentric, both immune and non-immune immune complexes mediated glomerulonephritis. Then we discussed the histological correlates of specific etiologies that present with nephritic syndrome. That was your in your first discussion, that is Goodpasture syndrome. your IgA nephropathy, and your infection-associated GN. And in today's discussion, what we've discussed, what we've talked about is the histological correlates of specific etiologies that present with nephritic syndrome, with sometimes having nephrotic range proteinuria. Okay, so this included membrano-proliferative glomerulonephritis, your C3 glomerulonephropathy, your plasma cell dyscrasia related glomerulonephritis, and I your plasma cell dyscrasia related glomerulonephritis, and I hope it is clear now what is the entire spectrum of MGRS. So that we've understood the entire spectrum and we've correlated it with what we find, what how we define them prior to the availability of your electron microscopic images. And we've also discussed the histological correlates of microangiopathic hemolytic anemia. That is what is called thrombotic microangiopathy. So we've discussed what constitutes thrombotic microangiopathy under a microscope. So that brings us to the end of this discussion. In the next discussion, we'll be going ahead and talking about interstitial nephritis and then the histology of interstitial nephritis. So I'll look forward to seeing you in that discussion.